Ankylosing spondylitis is a chronic inflammatory disorder that most commonly affects the sacroiliac joint, the joint between the sacrum and the ilium bones of the pelvis, and also the joints of the spine. Now, if we break down the name of this disease, spondylitis means inflammation of the joints of the spine, and this is essentially what AS is, and this causes pain and discomfort. Ankylosis is when new bone formation in the spine causes it to fuse in a fixed, immobile position. So, who gets AS? Well, it is more common in men at a ratio of 6 to 1. The peak onset is 15 to 35 years old. In addition, patients with AS are often HLA-B27 positive. Spondyloarthropathies are a group of arthritic conditions that are HLA-B27 positive and affect the spine and nearby joints. These include psoriatic, reactive, and enteropathic arthritis, as well as AS. As well as being HLA-B27 positive, these diseases are rheumatoid factor negative, and so this is an important difference between diseases like rheumatoid arthritis. How might a patient present with AS? Symptoms include back pain. The pain will be characteristic as being worse at night, worse in the morning, and often lasts for around 30 minutes or more. The pain will improve with activity, and so these features differentiate it from mechanical back pain. Pain often occurs initially in the SI joints and radiates to the hips and buttocks. As well as pain, the patient will have stiffness of the spine and may report a reduction in mobility. AS and other HLA-B27 associated conditions are associated with anterior uveitis. It occurs in 20 to 30% of patients with AS. This eye condition may present with photophobia and watering and redness of the eye. This can be severe and may require emergency treatment to prevent visual loss. On physical examination, patients may present with a stooped posture, often described as a question mark posture. This is a result of exaggerated thoracic kyphosis and loss of lumbar lordosis. Patients with AS will often have a positive Schober's test, which suggests fixed flexion deformity. Watch our examinations video for more information on the Schober's test. The patient may exhibit a decrease in chest expansion, as well as spinal movement in general. AS can also result in extra-articular manifestations of the disease, and this occurs in 40% of patients. As mentioned previously, anterior uveitis can occur in patients with AS. CVS involvement occurs in less than 10% of patients, and usually in patients who have had AS for a while. Aortitis of the ascending aorta can result in aortic regurgitation, and fibrosis of the conduction system can cause AV block, potentially even complete heart block. Lungs can be affected not only due to costovertebral and costosternal involvement, causing decreased chest expansion and thus restrictive lung disease, but pulmonary fibrosis of the upper lobes can also occur. Kidneys can be damaged by amyloidosis, but this is very rare. And immunoglobulin A, IgA nephropathy, is also associated with AS. Neurological involvement can occur usually secondary to fractures of the spine. AS patients are also more prone to atlantoaxial subluxation, which can result in cervical myelopathy. Cauda-equina syndrome is also possible in patients with long-standing disease. Metabolic bone disease can also occur, and osteopenia and osteoporosis can increase the risk of fractures. X-rays are very useful for imaging people with established disease. They may not be useful in a patient presenting with early disease, as the X-ray may appear normal. Two things should be looked for on X-rays. These are sacroiliitis and bamboo spine. Sacroiliitis initially shows as blurring in the lower part of the joint. Then, as the disease progresses, sclerosis will occur and widening or fusion of the joint will occur. Bamboo spine occurs late on in AS. Initially, the vertebral bodies may become squared. In later stages, syndesmophytes form between vertebrae, and there is ossification of the spinal ligaments. In very late stage of the disease, there may be complete fusion of the vertebral column. This is known as bamboo spine. Treatment of AS includes physiotherapy and exercise programs such as postural training to maintain function. There are no medication that cure AS. Some medications can improve symptoms, like NSAIDs. When these do not work, doctors should consider simple analgesics for pain relief. Corticosteroid injections can relieve sacroiliitis pain. Oral corticosteroids can be beneficial in short term, but increase the risk of osteoporosis. TNF-alpha inhibitors can be effective when AS is poorly controlled with NSAIDs. Surgery is not commonly carried out with AS, but can be useful to correct spinal deformities or repair damaged peripheral joints. However, this is not commonly done due to the risks associated with potential neurological complaints. Thanks for watching, and I hope you found this useful.